afternoon. Thank you for attending this month's OCHIN Grand Rounds. I am your host, William Pinnock, and today I cannot be more excited to host Drs. Jonathan Todd and Dr. Michael Lieberman of OCHIN as they present on new initiatives to enhance STD reporting and clinical decision support within the OCHIN network. Dr. Jonathan Todd is an assistant investigator with OCHIN and an infectious disease epidemiologist by training. He is interested in using electronic health record data to address disparities in patients suffering from infectious diseases and utilizing community health centers for their healthcare. Dr. Michael Lieberman is the medical director for population health at OCHIN and a practicing internal medicine physician at Oregon Health and Science University. Dr. Lieberman has provided crucial informatics and clinical expertise to several OCHIN initiatives involving clinical decision support within the OCHIN EHR, including projects addressing latent tuberculosis, HIV PrEP, and STDs. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the chat box. This presentation will last approximately 45 minutes, with 15 minutes at the end to answer any questions you may have. We will now pass the mic to Drs. Jonathan Todd and Michael Lieberman for new initiatives to enhance STD reporting and clinical decision support within the OCHIN network. Drs. Todd and Lieberman, the floor is yours.
Thank you very much, William, and I appreciate your gracious introduction, and it's really exciting to be here and to share some of our results with electronic case reporting for STDs. So let me pull up my slides. Can you see them?
Yes.
Okay, and can you see, are you seeing presenter view or regular view?
Regular view. Excellent.
Well, thank you again, William. And again, really excited to be here with Dr. Lieberman to talk about some initiatives we're doing for STD reporting and to improve clinical decision support. Just to outline the talk, the plan for today is to update you on these initiatives related to STD reporting and clinical decision support at OCHIN. First, I'll discuss some recent data on STD prevalence across the US and in Oregon. Unfortunately, we are very much in the grips of an STD epidemic. And then I'll discuss our results from the electronic case reporting adoption project within Oregon. And I'll pass it along to Dr. Lieberman, who will discuss our new clinical decision support pilot working with Codman Square in Massachusetts. This project was really a multi-organizational project with many really hardworking stakeholders. I'd like to thank all of these co-authors who contributed to this work across the 4 organizations, including stakeholders from OCHIN, from the Oregon Health Authority, from the Public Health Informatics Institute in outside of Atlanta, Georgia, and of course with the CDC as well. Really special thanks to our colleagues at the Oregon Health Authority who continued really great work on this project in the midst of the COVID pandemic. So we truly appreciate their work, and we could not have done it without their help. So just to give some background on STDs in the United States, in 2018, there were nearly 2.5 million total STD cases, with over 1.7 million chlamydia and 583,000 gonorrhea cases. You can also see kind of relative increases since 2017. The relative increases of syphilis, particularly congenital, primary and secondary syphilis, are quite concerning. And really, this has been a problem for the last five years, and has not shown signs of abating. And there's conflicting information on how the COVID pandemic has really affected STD reporting and whether any lowering of cases in 2020 actually represents actual lowering of cases or just lowering of reporting. So much more to come on that. So here we have some data from the CDC just giving some history. This is a line graph showing the rates of reported cases of gonorrhea in the US by year from 1941 to 2018. In 2018, there were a total of 583,405 cases of gonorrhea reported in the US. So that's a rate of 179.1 cases per 100,000 population. You can see that there's really a peak around the mid 70s and a steady lowering really until about 2008. And a worrying kind of rebound, and this is sort of reflected in most STDs. But during 2017 to 2018, the rate of reported gonorrhea cases increased 5% and increased 82.6% since the historic low in 2009. Here we see a line graph showing the rates of reported cases of gonorrhea in the United States by race and Hispanic ethnicity from 2014 to 2018. In 2018, the rate of reported gonorrhea cases remained highest among Black Americans with 548.9 cases per 100,000 population. During 2014 to 2018, for all 5 years during that period, the gonorrhea rate increased among all race Hispanic ethnicity groups. So really a disease that is disproportionately affecting Black Americans, American Indian, Alaska Natives, Native Hawaiian, and Pacific Islanders as well. So before we get into the specific details of our project, I wanted to add some quick context here about chlamydia and gonorrhea, forming a very large proportion of the reportable disease burden, especially here in Oregon, which is why automating public health reporting from providers' electronic health records systems for these two conditions warrants special attention. In 2018, there were 19,224 cases of chlamydia, which represented a 155% increase overall since 2014. 5,913 cases of gonorrhea, also representing a 155% increase, and 424 cases of syphilis, representing a 318% increase in infectious syphilis cases among women since 2014. Here we show some data comparing trends in Oregon and the United States between 2010 to 2017. For gonorrhea and chlamydia, you can see that unfortunately for gonorrhea, while the cases per 100,000 population is lower than the general U.S. population, the lines are unfortunately getting closer together, and both for both gonorrhea and chlamydia, and both are increasing over time. Particularly gonorrhea. It's been a pretty sharp increase between 2013 to 2017, but really mirroring kind of the national trends in STDs. Here we have some data on syphilis trends. Again, similar patterns. The syphilis trends in Oregon actually are really roughly very similar to the US trends. Whereas with the gonorrhea and chlamydia, they're slightly below national trends. And you can see kind of an increasing incidence of early syphilis among women, and cases of congenital syphilis in Oregon continuing to rise between 2013 and 2018. So it's really a big problem, and something that I know the Oregon Health Authority and local public health jurisdictions are really trying to focus lots of resources on, and accurate reporting of cases is crucial to any effort to really intervene on transmission trends in STDs. So we really want to find ways to improve data reporting, and our automated kind of electronic case reporting adoption approach is really a step in that direction. So I'm going to walk through some slides talking about data exchange and how that works at OCHIN between OCHIN clinics, and this is generalizable beyond OCHIN, but but really to illustrate the predominant data transactions that support public health reporting for chlamydia and gonorrhea. Among other conditions, here we have a couple of context diagrams for how electronic case reporting for STDs are currently set up and how it is in practice. So currently, providers can report STD cases to their local public health authorities in various formats, which may include faxing and manual web form entry, which can be pretty burdensome for the clinical staff and requires human intervention. And many, as we all know, our community health centers and federally qualified health centers across OCHIN are serving really often serving underserved populations and just have many burdens upon them. And any way we can automate those processes, really, we want to do that if we can. But while the current state of STD reporting varies from state to state, in many instances, it's the health department that initiates outreach to the provider based on the receipt of laboratory data for a particular patient. And so this graphic just shows a clinic placing a lab order that goes to a lab, and the lab will report back to the clinic with the lab result, and will also report to the state or local public health entity with that lab result. And then the clinic will, in the case of a positive lab, will send a case report to the state or local public health authority. In Oregon, that would be the Oregon Health Authority. And that can take many different formats. But in reality, the burden of provider reporting means, clinicians frequently rely on lab reporting to make public health authorities aware of STD cases. And lab reports alone are unlikely to provide public health with all of the data they need to conduct a case investigation or to follow up with a patient. So the electronic lab reporting simply wasn't designed to substitute for clinician reporting, which is the reason why often it ends up falling on the shoulders of public health departments to need to reach out to the clinician to get extra information. But sometimes even those types of follow-ups can be challenging because many ELRs may lack the clinician's contact information. So clearly this is a process that we hope to improve upon. It is, again, it's SC reporting is required by law in Oregon and I believe all states. And so we're really hoping to improve upon that. So what we envision is, and what we have tried to implement, is a state where reporting is less burdensome for both clinical and public health stakeholders. Automating case reporting, which is known commonly as electronic case reporting, or eCR, stands to improve data quality and timeliness, all while leveraging the data that is already in the electronic health record. This automation stands to decrease provider reporting burden, which we really, really want to focus on, and supplement the data public health agencies already receive via laboratory reporting. And this can also provide the public health departments with important data elements such as patient demographics, contact information, and treatment information in a much more standardized format. So our project goal was to increase standards-based eCR, electronic case reporting, of chlamydia and gonorrhea between healthcare providers and their jurisdictional public health agencies, in this case, the Oregon Health Authority. So as you know, OCHIN is a health center controlled network and has separately incorporated this process into our existing information systems. For this project, we've integrated predefined case reporting criteria within the EHRs to determine if a given patient encounter met public health reporting requirements for chlamydia or gonorrhea. We then determine at what point in the existing workflow to evaluate this criteria against the patient encounter data, which included, for example, when the provider closed the encounter, when a lab result was received, or when a lab result was manually entered into the EHR. Once the appropriate encounters are identified, the encounters are summarized with the case report data elements. And many of these elements are identified by the Council of State and Territorial Epidemiologists, the CSCE data elements for case reports. So in other words, it's not the entire patient encounter that is sent to public health, but rather a subset of that data that is required for public health to review and for further investigation as needed. So this slide illustrates the STI case detection logic created with input from state and local surveillance and informatics subject matter experts. The case detection is based on patient encounter data in the provider's EHR or other health IT system within the clinical environment, in this case, the OCHIN EHR. If the logic is satisfied for a particular patient encounter, the system will create and send the case report on to public health. The model value sets use codes from standard health IT vocabularies, including ICD-10, LOINC, and SNOMED CT. However, these standard code concepts have to be mapped based on what data types and codes are actually available in the EHR. So while the initial model logic have created 3 different scenarios, the 2 EHRs used in these pilot studies only contained codes that reflected 2 of the 3 scenarios. The first scenario reflects that if a patient's diagnosis code is in a predefined list of codes for either chlamydia or gonorrhea, the logic is satisfied. An example of a diagnosis code for scenario 1 is the ICD-10 CMA56.01 code for chlamydial infection, unspecified. The third scenario, we did not implement scenario 2 for our case detection logic, but the third scenario we did implement requires that a patient's record must include both a code for a lab test that was performed and a code for the lab result. So an example for scenario 3 is a LOINC code for chlamydia trachomatis rRNA presence in unspecified specimen by probe and target amplification method, and an abnormal result flag. So the content of the case reports are defined by Health Level 7 or HL7, a standards development organization for health information, and as referred to as the Electronic Initial Case Report, or eICR. These case reports were batched together and sent from the electronic health record to public health on a schedule consistent with jurisdictional reporting guidelines, while they could also be sent real time if desired. So the screenshot on the left is a paper case report that may be faxed from a provider's office to the Oregon Health Authority. The screenshot on the right illustrates some of the key data elements contained in the eICR, such as patient name, date of birth, reason for visit, problems, lab results, medications administered, other medication history, etc. eICR also includes other data elements that we aren't showing here in this sample. In Oregon, we used SFTP, Secure File Transfer Protocol, between OCHIN and OHA to exchange these batches of eICRs. OHA then mapped the eICR data elements to their existing surveillance systems data model and made the case reports viewable to select system users. Here you see the high-level workflow for ECR for the Oregon implementation. OCHIN recruited 3 member clinics to pilot this approach for chlamydia and gonorrhea, including two clinics within the Portland metro area and 1 clinic in Eastern Oregon. And I'll just briefly walk through the workflow. So at a participating OCHIN member clinic, a patient's encounter data would be entered into the OCHIN Epic EHR. The EHR registers a clinical update, such as a problem list entry, a diagnosis, or lab findings. From there, we execute STI case detection logic upon an encounter close, interface results, or manual lab entry. If the logic indicates a match found, the case report is populated with patient data, and the case report is then sent on to the Oregon Health Authority. From there, the OHA has to process the data. It receives the case report via the Orion Health Rhapsody system, and then inserts the data into the Orpheus system, which is the OHA's homegrown system for ingesting electronic lab reports and case report data. An acknowledgement is posted to the FTP server once hourly. The case reports are deduplicated, which is a manual process. And the data sources are consolidated in Orpheus, which is also a manual process. And then there's an assessment if the patient has received the STI diagnosis, and then you conduct case investigations linked to treatment, et cetera. So at that point, there's follow-up with the patient. So the entire workflow is not automated from the OCHIN side and from the participating clinic side. It is automated, but there is still some manual processing from the Oregon Health Authority side, and that's something that we hope to improve upon in future implementations. So OCHIN and the OHA teams separately evaluated the case reports that were generated from the study after 15 weeks of the intervention period. We've highlighted here some of the areas we decided to review in our summary of findings that we'll go through in my next slides, including case detection frequency, which is the percentage of generated eICRs that were created by the various value sets and codes, case report completeness, how complete is the eICR at the time of creation, eCR throughput, how many eICRs were received during the study period, what is the average and range of eICRs for a given case, and then an eICR to ELR comparison. And really that was the heart of what we were hoping to learn, was how does the existing eICR case detection logic and associated value sets compare to ELR in our jurisdiction? How do data received via eICRs compare to ELRs for similar patient and provider contexts? Does this work as well as the ELR process, which involves human input and requires time from clinical staff? If we can get the same information from an automated process through the eICR, then that really removes some burden from clinic staff. Start walking through some results. Here we have information on case detection frequency, and really this shows you for chlamydia and gonorrhea. For chlamydia, there were 154 detected codes. For gonorrhea, there were 232 detected codes. And you can see the breakdown of the type of scenarios that were created. For scenario 1, the majority in both chlamydia and gonorrhea were scenario 3, essentially. The lab test was performed, and there was a lab result indicating the presence of a organism. So more so than the diagnosis code, which is scenario 1. So slightly more of the scenario 3 for chlamydia, about 63%, than in gonorrhea, which is about 56%. Here we have some data on case report completeness for all 365 case reports that were generated during the 15-week time frame. You can see sort of the number of eICRs with the data element populated in the percent complete. So many of these elements are not, and we did do a small comparison between some of the a sample of the ELRs and the eICRs for case report completeness, which I'll show in a few slides. But many of these data elements are not available with electronic lab reporting. So, facility phone, patient name, patient phone, et cetera. You just didn't see that data populated in the ELR. But in many cases, this is just standard data that is found within the electronic health record. So that is a really kind of a major benefit of the automated eICR approach. For eCR throughput, 328 out of 365 eICRs, or 90% received, were found to meet the Oregon Health Authority's case definition. There were 37 eICRs that did not meet that case definition, and we list the different reasons why an eICR was not accepted, essentially. The most common reason that an eICR did not meet case definition was the lack of positive lab results, meaning no lab results were received by any mechanism. There were a couple other mechanisms here. Patients were not Oregon residents. It was a mistaken COVID result. Case was already reported, and a telemedicine visit with orders for a lab without results. But most common reason was no positive labs. And here we have ECR more data on ECR throughput. The count of unique patients with at least one valid eICR was 184. The count of unique patients reported via ECR during the study period originating from participating clinics was 196. And multiple eICRs can generate based upon when data was updated. So, for example, if treatment information was added to the electronic health record maybe 3 or 4 days later after the initial generation of the first eICR, a second eICR might be generated with treatment information, for example. So the average number of eICRs generated for chlamydia was 1.5, and then the average number of eICRs generated for gonorrhea was 1.9. Here we really have an eICR to ELR comparison for chlamydia, and the OHA's Orpheus system captured 131 total chlamydia cases across the 3 participating clinics during the study period. Again, that was February 3rd, 2020 through May 15th, 2020. And at least one eICR was associated with 72% of the cases. Of note, 8 of these chlamydia cases had neither an eICR nor an ELR attached, but were reported via another mechanism such as the electronic provider morbidity report. But the eICR case detection logic identified 6 additional chlamydia cases not reported via ELR. There were also 29 cases that were sent in via ELR that were not picked up via the eICR method. We suspect this may be because of patients may have had a lab test that essentially was placed out. A lab test was performed, but the positive lab result was not actually entered into the EHR and thus didn't trigger an eICR. So in this case, there was definitely some cases that were missed by the eICR approach, and I think we're continuing to sort of improve the algorithm to see if we can remove some of those cases. For gonorrhea, the eICR approach actually performed a little better than it did for chlamydia. The Orpheus surveillance system captured 117 gonorrhea cases across the 3 participating clinics. At least one eICR was associated with 88% of the cases. 7 gonorrhea cases, again, this no category, had neither an eICR nor an ELR attached, but were reported via another mechanism, such as the electronic provider morbidity report. So in this case, actually, the eICR performed better than the ELR. The eICR case detection logic identified 15 additional gonorrhea cases not reported via ELR, whereas there were 7 cases that ELR identified that eICR, the automated eICR process, did not identify. And here we have a sample of sort of 20 cases where we compared the data completeness, the eICR to ELR comparison, and you can see that uniformly the data completeness is much higher with the eICR. So you get a much richer set of data that goes into the report. Diagnosis information isn't available in the ELR, medications administered, immunization status, symptoms just aren't available in the ELR, and really just uniformly across the board, particularly looking at race ethnicity data, it's much higher in the eICR data versus the ELR data. So just some summaries of our experience with eCR for STI here in Oregon. We were really fortunate to work with really motivated clinical partners, including both our clinics that we worked with in Oregon and also the Oregon Health Authority. Again, we were fortunate that OHA already had a homegrown surveillance system, which really helped us to kind of allow for in-house customization and a high degree of flexibility, and really a robust, well-established practice of ELR for reporting cases to the state. We had some barriers throughout the study. There was significant regulatory and compliance barriers for data exchange, and that took considerable time out of our study, out of our kind of project period. As far as the process of mapping the eICR data to surveillance systems will be highly variable across different public health jurisdictions and different states. and certainly requires special expertise. One major barrier, of course, was the COVID-19 pandemic. Our study period, again, February through May, was really just overlapped through like the worst of the initial COVID period. 2 of our 3 clinics actually had closures, staff reassignments, surges of COVID EICRs, et cetera, that were conflated with STI EICRs. So nothing you can do about that, but just something to keep in mind. And I think certainly there's a lot of emerging research showing kind of depressed numbers of STD reporting across the nation, but how much of that is real and how much of that is just lack, of clinic closures, just switch to telehealth and less screening, et cetera. So really just some future recommendations to coordinate with the EHR vendor on additional features and functionality, sort of examining and improving the algorithm that we used for triggering case reports off of diagnosis data, and also on laboratory results, and examining lab workflows for patients, workflows for lab reporting and reporting of data back to clinics. Sorry, my dog is I think is dreaming. So anyway. Our partners at PHI, the Public Health Informatics Institute, have put together a really interesting eCR for STIs toolkit that's available here, and really has resources for adopting the eCR approach. And all in all, we found that eCR added value, and we've determined to maintain the data feed between the clinics and OHA. So just some ECR conclusions. We found that electronic case reporting was generally as effective at identifying gonorrhea and chlamydia cases as electronic lab reporting, with certainly in the 2 different diseases. In gonorrhea, the automated approach actually identified more cases, whereas for chlamydia, the electronic lab reporting process identified more cases. ECR data completeness was substantially higher than that found in the ELR reports. And the ECR process is automated and engenders no burden on staff to input lab reports into the Orpheus system. So that's a real benefit to the ECR approach. Now I'm going to go ahead and pass it along to Dr. Lieberman, and he's going to talk about a new project that we're working on with clinical decision support for STDs.
Thank you, Jonathan. Yes, so we have a patient that has been diagnosed with, in this case, gonorrhea. The ECR has gone off, and now what do we do with the patient? So I'm going to talk about clinical decision support, and I thought I would start with just a brief definition. This is from the healthit.gov site, which says clinical decision support. I mean, a lot of people, it's thrown around a lot. It can mean a lot of different things, but I thought this was a pretty good definition. So clinical decision support provides clinicians, staff, and patients or other individuals with knowledge and person-specific information intelligently filtered or presented at appropriate times to enhance health and health care. Really, it's about enhancing decision-making in the clinical workflow. Go ahead to the next slide. So the project that we're working on is really focused on a pretty specific set of workflows. So again, we diagnose a patient with gonorrhea. We then need to come up with the appropriate treatment for that patient. And then once that's completed, because people with STIs are at increased risk for HIV, we want to have a conversation about HIV testing and conduct appropriate HIV testing. And then after that's done, again, because of the increased risk for HIV, we should discuss PrEP, pre-exposure prophylaxis, with the patient. So we want to see what sort of tools we can put in place to enhance these workflows. Go ahead to the next one, please. So this is a project that we are working on with some partners. We are working with the Public Health Informatics Institute. We have a number of people at OCHIN working on it, and then the CDC is also involved in this project and are very interested in how we can kind of automate the delivery of this clinical decision support through the EHR so that everybody doesn't have to come up with it on their own. Go ahead to the next slide. And within OCHIN, we are piloting with one of our sites, Codman Square Health Center. They're in Boston, and we will be implementing the CDS workflows in that clinic. It'll be a combination of, in Epic Speak, smart sets and smart forms, which are documentation templates, and order sets that will accommodate their existing workflows for treating gonorrhea. The system is supposed to be piloted this summer. Go ahead to the next slide, please. So the first part of this is treatment. And for treatment, there are really two ways that patients can come into this pathway. First of all, they may show up at the clinic with symptoms, in which case we usually would initiate treatment presumptively, or they oftentimes will get scheduled for general STI screening, in which case the result will come back at some point, and then the patient will be brought back to clinic for treatment of that. And this is a flow sheet that we're working from. It has a lot of branch points. It's pretty complicated, but again, we are going to be focused on a pretty narrow workflow. And for this, again, so just how does this relate to clinical decision support? Well, it is a clinical guide. I mean, we're adapting a clinical guideline. And then in this case, we're going to be looking at documentation templates. The documentation templates will be used to collect necessary information that will guide treatment, and it will guide decisions further down the road. And then we will have condition-specific order sets as well that will give the clinicians easy access to the interventions that they need. Go ahead to the next slide. And we are incorporating some updated gonorrhea treatment guidelines from the CDC. At the end of last year, they came out with this recommendation about treatment, which was a single 500 milligram intramuscular dose of ceftriaxone for uncomplicated gonorrhea. And then for those presumptive cases where you don't know that it's not chlamydia, you also include doxycycline 100 milligrams twice daily for 7 days. So this will be part of the intervention that we're doing. Go ahead to the next slide, please. And so then now you've treated your patient for gonorrhea, and the next steps around there, again, are screening for HIV disease and, when appropriate, referring them for treatment, for PrEP treatment as well. So this, in this case, we do need, we again use documentation templates. It's actually the same documentation template that we used for the last one, but it's also notable that we're not only providing the template for the providers, we also are going to be providing an online form for the patients to fill out. So it can be, so if it's a screening appointment, it can be pushed out to them before the appointment. They can put in information about their sexual history that we can then use to guide the rest of that visit. It also will have computerized alerts and reminders, and the alerts and reminders can, again, both be for the clinicians at the visit. So now in this case, we're talking specifically about people that have been diagnosed with gonorrhea, so it's going to flow pretty regularly as to what we're going to do in the rest of the visit. But we could have alerts elsewhere in the system if, for example, a patient is found to be at high risk for HIV, that would prompt a discussion of PrEP. And then we also have reminders. So we can, again, through the online tools, we can pop up a reminder for a patient when we know that they're at high risk to contact the clinic either for their routine screening that is due, or perhaps you could do something about discussing PrEP with your provider or something like that. But the key is that we can push it out to the patient so it can work asynchronously. It's not only going to be based on when the patient is in the clinic, but we can do things for when they're not in the clinic. Go ahead to the next slide. And this is just an example when we talk about order sets, or in Epic Speak, a smart set. It's a way of selectively showing providers the appropriate things to do. So we can make it, one of the things we always talk about is making it easy for them to do the right thing. So we all know that we have to put visit diagnoses when we see patients. So instead of making them search for the appropriate diagnosis, we can have that available in the smart set. So it's just and this is an example around a pre-exposure prophylaxis or PrEP. So they can just select that easily. We can have links to the documentation templates, so it makes it easy for them to prompts them to collect the appropriate information for the patient, gives them a series of either buttons or drop-down menus or other things that can make it easy for them to capture information in a structured format, which can be useful later. And then we can give them, we can let them know what labs should be ordered and make it easy to order those labs. So for PrEP, I mean, this is a set of labs that we would basically do at any visit. I guess creatinine doesn't have to be every visit, but most visits or some visits. So we can make it really one click to order all of those labs. If it's your initial visit, there's some additional labs we would want to order, so those are available. And then we can have the prescriptions ready to go. So we can have, with all the instructions preset, the quantity in there as well, the fact that you're probably not going to give refills because you want to see them back. So that can all be set. So they really just can, again, have, one click or two clicks and order the appropriate medication. We can include other things that are commonly done during these visits, so like vaccinations for these other things. So that's kind of the tool set that we have. And again, what we've done is, we're basing this clinical decision support on CDC guidelines. We're going to include documentation templates that are both for clinicians and patients. And then we're going to create alerts and reminders, as well as these order sets or smart sets to facilitate that care.
Thank you, Dr. Todd and Dr. Lieberman, for that insightful presentation on electronic case reporting. And thank you to everyone who attended today's session. Be sure to follow the CDC on Twitter at @CDCGov. Follow the Oregon Health Authority on Twitter at OHA Oregon. And follow OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, be sure to head over to OCHIN.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And OCHIN Grand Rounds will return on March 12th with Dr. Erica Cottrell of OCHIN and Oregon Health and Science University presenting on the Health Experiences Research Network. So from all of us at OCHIN, have a great rest of your weekend. Stay healthy out there.